Hello everyone. Today we will discuss about newborn examination. Learning objectives, classification of newborn, understand apgar score, assess growth measurements, assess vital signs, estimation, estimate the gestational age, assess the different body system, recognize normal finding in newborn examination, and recognize common newborn problems. Classification of newborn, classification by gestational age. Newborn who delivered before 37 weeks of gestation called preterm. Full term calls delivery within 37 to 40 weeks of gestation, and postterm called more after the 42 weeks of gestation. Classification by birth weight. Low birth weight babies less than 2500 gram, very low birth weight babies less than 1500 gram, and extremely low birth weight babies are under less than 1000 grams. Classification by weight percentile. AGA appropriate for gestation, that is 10 degree to 90 degree percentile of for GA. Small for gestation, less than 10th percentile for gestational age. Large for gestational age, more than 90th percentile for gestational age. Not all term infants are the same. As you can see, there are three pictures. They are all term babies, but in a different weight. Small for gestation, symmetric. Head circumference, length, and weight is less than 10th percentile. 33% of babies, infants are landed in SGA in symmetric form. Asymmetric, weight is less than 10th percentile. Head circumference and length are normal. 55% of infants are in asymmetric. Causes due to placental insufficiency, chronic hypertension, diseases preeclampsia, chronic abruptio placenta, hemoglobinopathies, altitude, placental infarction, and in combined form, asymmetric and asymmetric etiology occur. 12% of SGA infants are land in this. Smoking, drug causes are smoking, drug, placenta infarction, or chronic abruptio placenta villamentis insertion. And large for gestational age, etiologies are infants of diabetic mother, backward Widman syndrome characterized by macroglossia, visceromegaly, macrosomia, umbilical hernia, or omphalocele, and neonatal hypoglycemia, other than hydrops fetalis in large mothers. Now the apgar score, as you can see, apgar chart. Scoring is divided into heart rate, respiratory effort, muscle tone, and reflex, and the color of the baby. It also scoring is in 0, 1, and 2. Heart rate is absent 0, less than 100 beats per minute 1, more than 100 beats per minute 2. Although apgar score should be more than 7, it is a good apgar score, and if less than 7, we that indicates a baby need a medical attention. As we are assessing a apgar score, assess the physical condition of newborns after delivery at 1 or 5 minutes and every 5 minutes until its value is more than 7. A value is more than equal to 7 indicate the baby condition is good or excellent. Good to excellent. A value less than 4 necessitate continued resuscitation. apgar score is good predictor of survival, but using it to predict long-term outcome is inappropriate. Now we will start with the examination of newborn. Complete physical examination should be done within 24 hours of birth, which include the following: vital signs, physical examination, neurological examination, and estimation of gestational age. Now we will start with the vital signs, which include temperature, heart rate, respiratory rate, blood pressure, and capillary refill time. First is temperature. Temperature should be taken axillary. The normal temperature for infant is 36.5 to 37.5 degree of Celsius. Axillary temperature is 0.5 to 1 degree Celsius lower than the rectal temperature. Next is heart rate. It should be obtained by auscultation and counted for a full minute. Normal heart rate for newborn are 120 to 160 beats per minute. If the infant is tachycardic, heart rate must be more than 170 beats per minute. Make sure the infant is not crying or moving vigorously. After the heart rate, count for respiratory rate. Normal respiratory rate is 40 to 60 beats respiration per minute. Respiratory rate should be obtained by observation for 1 full minute. It should not be less than that. No, newborns have periodic rather than the regular breathing. In blood pressure, it is not measured routinely in newborn. Normal blood pressure varies with gestational age and the postnatal age. And the last in vital sign, capillary refill time. Normal is less than 3 seconds over the trunk, maybe as long as 4 seconds on extremities, or delayed capillary refill time indicate a poor perfusion in newborn. After the vital signs, physical examination can be done in newborns. First examination should be done in the delivery room after the delivery, and second examination are more detailed examination after the 24 hour of birth. In during discharge examination, within 24 hours of discharge from the hospital, we have to do a physical examination of newborn. Now we will start with the first is measurement. There are three components for growth measurement in newborn neonates, that are weight, length, and head circumference. All should be plotted on standardized growth curves for the infant's gestational age. As you can see in this picture, this is a growth curve chart. First is length, second one is weight chart, weight curve, and third one is head circumference curve. You can plot it here, plot a measurement here, and estimate a measure. After the measurement, weight is measured. Weight of full-term infants at birth is 2.6 to 3.8 kilograms. Babies are less than 2.5 kilogram are considered a low birth weight babies. Babies always also loses 5 to 10% of their birth weight in the first few days after the birth and regain their birth weight by 7 to 10 days. Weight gain varies between 15 to 20 grams per day. Next is length. Crown to heel length should be obtained on the admission and weekly. In newborn, length ranges from 48 to 52 centimeter at birth. Next is head circumference. Head circumference should be measured on admission and weekly using the measuring tape around the most prominent part of the occipital bone and the frontal bone. Head circumference at birth in term babies are 33 to 38 centimeter. Now the general examination of newborn. In general examination, first is color. Pallor associated with low hemoglobin or shock. Cyanosis associated with hypoxemia. Plethora associated with polycythemia, that is increase in number of RBC mass, jaundice elevated due to elevated bilirubin. These are the some pictures in cyanosis. As you can see, bluish discoloration of the baby. In acrocyanosis, extremities are in blue color. In jaundice, that is discoloration of baby in yellow color, just because of due to increase in bilirubin. After color, we have to assess a skin for purpura, ecchymosis, mottling, vernix caseosa, edema, Mongolian spots, and collodion infant. As you can see in this picture, vernix caseosa, lubricant found on the skin or skin folds, disappears as the fetus ages and almost absent in the postterm of the baby. In the picture, you can see purpura in the baby, which is a hemorrhage into the skin just due to the abnormalities in platelets, coagulation factor, or blood vessels. And in mottling, it occurs in response of hypothermia and disappears as the infant is rewarmed. The skin exhibits a lace-like pattern of dusky erythema over the extremities and trunk when the neonate is exposed to cold ambient temperature. In the next picture, edema and Mongolian spot. As you can see, the lower extremity is swollen. It can be occur in the edema of foot in Turner syndrome. And neck Mongolian spot, dark blue bluish like macular spot, usually over sacrum. In 90% of black and Asian newborns are suffered with this Mongolian spot. It also disappears by 4 years of age. Next is collodion baby. Collodion baby is a descriptive term for the infant who is born encased or in a tight, shiny membrane that resembles plastic wrap. The collodion baby is also not a disease entity, but in the first expression of some forms of ichthyosis. Next is rashes, melia, erythema toxicum, bolus impetigo, diaper rashes, and nevi. Melia, white papullae less than 1 mm in diameter, scattered across the forehead, nose, and cheeks. It also disappears within a week. Arrhythmia toxicum. It is a white vesicle with a red base. Also contain eosinophils. After 48 hours of the birth, it can occur. It contains transient. It is a transient and benign. This is the picture of bullous impetigo, also called pemphigus neonatum. Bullous impetigo begins with a small vesicles that become flaccid bullae. Exfoliated toxin A produced by us, it also produced by a Staphylococcus aureus causes loss of cell adhesion in the superficial epidermis. And also bullae contain a clear or yellow fluid which eventually progresses to become purulent or dark. This is the picture of diaper dermatitis. Due to diaper, candida diaper dermatitis can be occur in the baby. As you can see on the face of baby, this is a port wine stain Flat, deep, and red color stain which do not blanch with pressure. It also associated with retinal. It can be associated, may be associated with retinal and intracranial hematomas. Next is head and neck. In head and neck, first start with skull, macrocephaly and microcephaly, caputsuccedenum, cephalohematoma, subgaleal hemorrhage, fontanelle. This is the picture of hydrocephalus and microcephaly. Hydrocephalus is the buildup of fluid in cavities, also called ventricles deep within the brain. The excess fluid increases the size of the ventricles, and other than in microcephaly, it is a condition where baby's head is much smaller than the expected. This is the picture of caputsuccedenum and cephalohematoma. Caputsuccedenum is benign edema associated with birth trauma that crosses cranial suture line. On palpation, it is described as boggy, soft, and fluctuant. In cephalohematoma, it is a accumulation of blood under the scalp, especially in the subperistitial space. There is some complications of cephalohematoma, underlying linear skull fracture, jaundice, calcification, infection, and intracranial hemorrhage. This is the picture of subgaleal hemorrhage. It is a rare but potentially lethal condition found in newborns. It is caused by rupture of emissary veins, which are connection between the dural sinuses and the scalp veins. Blood accumulates between the epicranial aponeurosis of the scalp and the periosteum. Now, in the examination of eyes, pupil equality, reactivity to light, squint, cornea, conjunctiva, and iris we will examine. This is the picture of subconjunctival hemorrhage. It is a benign condition and also resolved within a 2 to 4 weeks. It occurs when a tiny blood vessels breaks just underneath the clear surface of your eyes or conjunctiva. This is the picture of congenital cataract. It is when the lens of the eye is cloudy instead of the clear at birth. It can cause a loss of uh, eyesightedness. This is the picture of glaucoma. A congenital glaucoma, which is also called newborn glaucoma. In this, child is either born with ocular enlargement or the enlargement of the eye is noticed within a month of a life. Uh, in that, IOP is raised in the intrauterine life, which cause a glaucoma. This is the picture of disconjugate eye movement. It is a disparity of visual when eye does not coordinate with each other. Now next is ear examination. Assess for asymmetry or irregular shape. Note the presence of auricular or preauricular pits, fleshy appendages, lipomas or skin tags. In low set ear, below lateral canthus of eye, associated with genitourinary anomalies because these areas develop at similar time. Malformed ear can be associated with Downs or Turner syndrome. This is the picture of ear tag. As you can see in the picture, Uh, there is a small lump of skin or fat or cartilage in front of the ear that some babies are born with this. Now the nose, patency of each nostril should be checked. Exclude choanal atresia. Flaring of nostril should be checked. As you can see in this picture, this this is a dislocated nasal septum. In the examination of mouth, we have to look for cleft lip and palate, tongue tie, natal teeth, and tongue size. As you can see in the picture, first picture is a cleft lip, and second picture is of unilateral cleft lip and cleft palate. This is the picture of bilateral cleft lip and cleft palate. Abstain pulse and cheeks. It is a small white cyst which contain keratin. It is frequently found on either side of the median ref of the palate and also resolved in 1 to 2 months of birth. Ranulas. It is a small bluish white swellings of variable size on the floor of the mouth, representing benign mucus gland retention cyst. This is the picture of normal tongue and the ankyloglossia, which is also called tongue tie, where the tongue loses the range of motion just because of when the frenulum fails to separate from the tongue before the birth. This is natal teeth. Natal teeth that are already present at birth. They are different from neonatal teeth, which grow in during the first 30 days after the birth. Now, the macroglossia and the oral thrush. Macroglossia is a rare condition that typically affect more children than adults. It also called enlarged tongue. And the oral thrush, it is a common infection in babies. It can be prevented by clean or thorough cleaning of nipples and oral cavity of the baby. In the examination of neck, cyst, thyroglossal cyst or cystic hygroma, masses in sternomastoid tumor in thyroid, and webbing of neck. This is the picture of sternomastoid tumor. It is a hematoma in the middle third of the sternomastoid muscle. Torticollis, limitation of the lateral rotation of the neck. As you can see, this is the picture of webbed neck. In musculoskeletal examination, we have to examine for the fracture, dislocations, polydactyl, syndactyl, and deformities. Here you can see a picture of Erb's palsy, which is a result from the injury to nerve roots, which is C5, C6, and with C7. Second one is polydactyl. As you can see, the extra finger are with extremities. This is the picture of syndactyl. Syndactyl is a condition in which children are born with fused or webbed fingers. This is the another picture of Talipes equinovarus, which is also called club foot. Now in the examination of spine and hips, inspect back for meningocele, examine for dislocation of hip, expected if there is a asymmetry of skin folds of the thigh and shortening of the affected leg. Next is meningomyocele. It is also called a common open neural tube defect. It is characterized by failure of the neural tube to close in a lumbosacral region. As you can identify with the figure, the difference between the meningocele and meningomyocele. In the second one, meningocele, it involves a defect of a posterior element of the spine with extrusion of meninges and CSF without the involvement of the neural elements. On the other hand, meningomyocele, it involves extrusion of meninges, cerebrospinal fluid, and the function of neural elements such as nerves or spinal cord components. Now the next is DDH, that is developmental dysplasia of the hip. Developmental dysplasia of the hip is a problem with the way a baby's hip joint form. Next is chest or lung examination. In inspection, supernumerary breast or nipple is common in 10% of the newborns. Breast enlargement secondary to maternal hormones. Unilateral absence or hypoplasia of pectoralis major. Poland syndrome due to widely spaced nipple. Turner syndromes or Noonan syndrome. In chest deformity, pectus carinatum much less common than pectus excavatum, more common in males by ratio of 4 is to 1. Narrow thorax with increased anterior posterior diameter of chest. Pectus excavatum is gender predominance. In boys 3 is to 1 is the ratio of pectus excavatum. Mild oval pit near inframental notch. In severe, sinking of entire lower sternum. In observation, respiratory pattern, brief period apnea are normal in transition called periodic breathing, chest movement symmetry, retraction and tracheal tugging in chest movement. In auscultation, audible stridor, grunting, wheeze and rail sound. This is the picture of slight substernal retraction, which is the evidence during inspiration. In the examination of heart and vascular system, tachypnea, tachycardia, increased periodical activity, cyanosis, hyperoxia test, auscultation of heart sound, murmur or irregular heart rhythm, perfusion, capillary refill time, palpate femoral pulsation, absent in coartation of the aorta, bounding pulses often indicated PDA. In abdominal examination, organomegaly, liver may be palpable 1 to 2 cm below the costal margin. Spleen is at the costal margin. Masses, distension, scaphoid abdomen, umbilical stump, bleeding, meconium staining, granuloma, discharge or inflammation, omphalocele or gastroschisis. This is the picture of abdomen in cylindrical shape. Here a normal umbilical cord with bluish white at birth with two arteries and a one vein. And the second picture is the meconium stained umbilical cord, which is in dark in color. Now next is emphalocele defect covered by amnion with the cord attachment to apex of the defect. Any abdominal organ can be herniated through the defect. Now this is the picture of abdominal distension, and you can see the distended abdomen of the baby. In the examination of genitalia and rectum, in male, in full term, scrotum is well developed with a deep rugae. Both testes are in the scrotum. In preterm, scrotum is small with few rugaes. Testes are absent or high in the scrotum. The abnormalities are undescended testes, hydrocele, inguinal hernia, or hypospadiasis. This is the picture of hydrocele or inguinal hernia. In bilateral hydrocele, as you can see, the enlargement of the scrotum in both sides, and in the bilateral inguinal hernia, in the inguinal area, uh, internal organ is protruded from the both side of the inguinal area. This is the picture of hypospadias. The meatus opening on the ventral surface of the penis, which is called hypospadias. In female genitalia, in full term female baby, labia majora completely cover labia minora. In preterm baby, labia majora is widely separated and labia minora protruded. In a discharge from the vagina or withdrawal bleeding may be observed in the first few days. Infants with ambiguous genitalia should not undergo gender assessment until endocrinal evaluation is performed. This is the picture of withdrawal bleeding and ambiguous genitalia. In anal examination, in perforated anus, the anus is inspected for its location and patency. An imperforate anus is not always immediately apparent. Thus, patency often is checked by careful insertion of a rectal thermometer to measure the baby's first temperature. Meconium should be passed in first 48 hours after the birth. Delayed passage of meconium may indicate imperforated anus or intestinal obstruction. Urine should be passed in the first 24 hours of the birth. Next is for neurological examination. In neurological examination, muscle tone, convulsions, neonatal reflexes like Moro's reflex, grasp, tonic neck, stepping and placing, rooting and suckling reflex are examined. First is posture. In term infant, normal posture is hip abducted and partially flexed with knees flexed. Arms are abducted and flexed at the elbow. Fists are often clenched with the fingers covering the thumb. Tone. To test the tone, support the infant with one hand under the chest. Neck extensors should be able to hold head in line for 3 seconds. There should be no more than 10% head tag when moving from supine to sitting position. This is the picture of hypotonia and opisthotonus from E. coli meningitis. Now the examination of neonatal reflexes, also known as developmental primary and or primitive reflexes. They consist of autonomic behaviors that do not require higher level brain functioning. They can provide information about integrity of CNS. Their absence indicates CNS depression. They are often protective and disappear as higher level motor functions emerge. First is Moro's reflex. Onset is 28 to 32 weeks of gestation. Disappearance in 4 to 6 months. It is the most important reflex in neonate period. Significance of Moro's reflex: bilateral absence, CNS depression by narcotic or anesthesia, brain anoxia, and carnivorous, very premature baby. Asymmetric response of palsy, fracture, clavicle, or humerus. Persistence beyond 6 months, CNS damage. In a suckling reflex, when a finger or nipple is placed in the mouth, the normal infant will start to suck vigorously. Appears at 32 weeks and disappear by 3 to 4 months. This is how we examine for the suckling reflex. We have to put a finger or nipple uh, in the mouth, and baby will start sucking vigorously. Next is rooting reflex. Well established in 32 to 34 week of gestational age, disappears within 3 to 4 months of birth, elicited by the examiner stroking the upper lip or corner of the infant mouth. The infant head turns towards the stimulus and opens its mouth. Palmar grasp, established in 36 week of gestation and disappears by 4th month, elicited by the examiner placing her finger on the palmar surface of infant's hand, and the infant's hand grasps the finger. Attempts to remove the finger result in the infant's tightening the grasp. In the grasp reflex technique, put the examiner finger in the baby palm with slight rubbing. The response of the infant is the grasp the finger firmly. In significance, absent depression to CNS, persistent damage is also in CNS. Now the stepping reflex onset is on 35 to 36 week of gestation, disappears by 6 weeks, elicited by the touching the top of the infant foot to the edge of the table while the infant is held upright. Infant makes movement that resemble stepping. While holding baby in upright position, then lower him till his sole touch table. Stepping movements start.